Hello friends and welcome back to Perspectives Pulmonology. This is Dr. Vaibo, consultant pulmonologist from Shiva Kasturi Chest Clinic, Kalburgi, Karnataka. What are we going to study today? We are going to discuss a very important and a very recently updated topic, that is GINA 2023. What's new? We are going to study what are the differences, major differences which are there from 2022. There are many differences which are very important and which are very minor. I selected the 9 major differences from 2000 compared to 2022. Okay. Without wasting much time, let's go to the first difference. This is the regarding the box of terminology for asthma medications. Okay, first one is maintenance treatment, second is controller, third is reliever, and fourth is anti-inflammatory reliever. First three names you have heard even in 2022, but it was not very clearly defined. But here they clearly defined it. And fourth is anti-inflammatory reliever. It is a newer addition. We will study one by one. First is maintenance treatment. That is asthma treatment that is prescribed for use on a regular basis on every day. Whether the patient has the symptoms or does not have the symptoms, when we use the treatment, that is your maintenance treatment. So what is the difference between the maintenance and controller then? See, I want you to concentrate here. The term maintenance describe mainly the prescribed frequency. It mainly describes the frequency of the administration, not the particular class of asthma medicine. Okay, maintenance treatment, it's mainly regarding the frequency of the administration, not the class of drug used. Means it is irrespective of whatever the class you use. If you use ICS, LABA, SABA, anything, that is not included in maintenance. It's mainly the frequency of administration. Second, controller, it is the medication which is used on daily and regular basis. That is your controller. Okay, understood? Controller is the drug class of drug used. Maintenance is the frequency of administration. Okay, this is a major difference which I want you to remember. Coming to the third, reliever. As you all know, whenever the patient has symptoms, for to get a quick relief, you use the drug that is known as reliever. What are the drugs here used? It could be either SABA or it could be either ICS, SABA, anything. That is your reliever. Coming to the fourth, that is anti-inflammatory reliever. As you all know, asthma is a chronic heterogeneous inflammatory disease of the airway. So it is anti-inflammatory and it is a reliever, not a controller. Means it is used whenever the patient has excessive symptoms. So what is the definition? Reliever inhaler that contains both a low dose ICS and a rapidly acting bronchodilator. Okay, that is, it means it should contain low dose ICS along with a rapidly acting bronchodilator. That is your anti-inflammatory reliever. So what are the drugs used here? It is budesonide formoterol, beclomethasone formoterol, and ICS salbutamol combination. These are the three drugs which are included in AIR. Clear? Maintenance, controller, reliever, and AIR. Second major difference, coming to the adults and adolescent, the treatment we have in previous also we had track 1 and track 2. Here also that is maintained. Step 1, step 2, step 3, step 4, step 5, everything is the same. The only the major difference here is added here in track 2 we have addition of as needed ICS SABA. Okay, as needed ICS SABA as an preferred, as an alternative for an reliever. Okay, understood? Remember this. Khatam. Third, here in children less than 5 years and younger, step 1, step 2, step 3, and step 5. Here they clearly mentioned which baby to be put on what step. The patient has infrequent viral wheezing and no frequent symptoms. There is no need of daily controller. Use as needed SABA whenever the patient has symptoms. That's it. The patient has frequent symptoms, that is use of more than equal to 3 SABA per year, would put the patient on daily low dose ICS. If the patient asthma diagnosis is confirmed, either could be either of the symptom variability or because of the PFT, we will put the patient on double low dose ICS. And in step 4, when the patient asthma is not controlled with double dose ICS, we continue the controller, that is double dose ICS, and refer to the specialist. This is regarding 5 years and younger. And coming to the fourth major difference, here the definition of mild asthma has a difference. Severe asthma, moderate asthma, there is no change in definition. Mild asthma, there is a mild change in definition which you need to know. Mild asthma is currently defined as the asthma that is well controlled with a low intensity treatment. Okay, which is well controlled with a low intensity treatment, that is as needed low dose ICS formoterol or as needed low dose ICS with SABA. Okay, we studied here. There I told you ICS SABA is a new inclusion. Okay, in previous 2022 we had mild definition as asthma which is controlled with step 1 or step 2, but here there is no mentioning of any step. There is only the low intensity treatment. Okay, that's it. Coming to the fifth major difference, there is imaging. As you all know, asthma diagnosis does not need any imaging, but in cases of uncontrolled asthma, just to rule out the other differential diagnosis, associated comorbidities, we need imaging. Here there is an addition of CT of sinuses to diagnose chronic rhinosinusitis with or without nasal polyposis, because we have newer biologicals which can be used if the patient has chronic rhinosinusitis with nasal polyposis, that is dupilumab, omalizumab, mepolizumab. So we can use this biological therapy if the patient has severe asthma with or without nasal polyposis. So because of that, they have included CT of sinuses in the imaging section. Coming to the sixth, there is a differential diagnosis. All the differential diagnoses are the same, only with the addition of pertussis this time. That's it. Coming to the seventh difference, that is rhinitis. As you all know, one airway, one disease. Allergic rhinitis patients are prone for allergic asthma. Allergic asthmatic patients are prone for your allergic rhinitis. So here the rhinitis, as you all know, is the inflammation of the airway. It could be either because of allergic or non-allergic. Allergic, if the patient has if the allergen is turned, if the trigger is turned to be allergic, if the patient has periodic symptoms. Okay, it could be the most common is your house dust mite. Others are mold. They suggest allergic rhinitis. And one more important thing which I mentioned is, again, an examination of the upper airway should be arranged for all patients with severe asthma. Okay. The management remains the same: ARI, allergic rhinitis in asthma, and the drug of choice is inhaled corticosteroids. If the patient has severe asthma and it is not related by inhaled corticosteroids, we can use the newer biologicals. That's it. Coming to the chronic sinusitis with or without nasal polyposis, as you all know, rhinosinusitis is the inflammation of the airway along with inflammation of the nasal airway, along with your sinuses, that is your rhinosinusitis. If it is called acute, if it is less than 12 weeks duration and more than 12 weeks if it is chronic. And here the patient can have sinus can have polyp and without polyposis, but it is characterized by two important symptoms. What is that? Nasal blockage or obstruction or nasal discharge. Okay, patient should have nasal blockage along with nasal discharge. It could be either anterior or posterior nasal drip. So what do we do for diagnosis? We need CT of sinuses, as we discussed earlier, to look for the DNS, which could be one of the differential diagnosis for asthma with allergic rhinitis. To look for the polyposis, we need your CT sinuses or we need your nasal endoscopy. That's it. Treatment, drug of choice, inhaled corticosteroids. But the patient, here we have, if the patient has severe asthma, we can use biological therapy, which are your mepolizumab, omalizumab, and dupilumab, as I already told you. That is the inclusion of chronic rhinosinusitis with or without nasal polyposis. Okay, one is because we have CT sinus which can detect, a nasal endoscopy which can detect the polyposis, and second is to treat the patient with severe asthma with chronic rhinosinusitis with polyps with your biological therapy. That's it. Coming to the 8, GINA 2023, 6 to 11 years has no change. Step 1, step 2, step 3, step 4, step 5 all remains the same. Coming to the drug, step 9, that is drug interaction. There are two major topics in which the drug interaction has been mentioned. One is regarding your COVID-19, second is your ABP. In COVID-19 patient, which you are using ritonavir boosted, okay, treatment, nirmatrelvir. Here there is an interaction with your ICS with salmeterol. Okay, there is an interaction with ritonavir boosted therapy along with ICS salmeterol with virenterol. So we ask the patient to shift to ICS with formoterol, who are using here this ritonavir boosted treatment. That is the first important drug interaction. Second, in ABPA patient, when you are using itraconazole, since as you all know, itraconazole is an cytochrome P50 inhibitor. Okay, cytochrome P450 inhibitor. So it increases the risk of ICS and OCS, that is oral corticosteroids, and it can cause your adrenal suppression and Cushing syndrome. First thing. Second, it can increase the adverse effect of the LABA. As you all know, LABA can cause your tachycardia. So it can increase the adverse effect of your LABA. Which are the two LABA which it increases the adverse effect? Salmeterol and virenterol. So we suggest shift to ICS with formoterol. Okay, both in COVID-19 and in ABPA, GINA 2023 ask the patient to shift them to ICS with formoterol if you are using ICS with LABA therapy. Okay, two topics where drug interaction is there. That's it. Okay, this is 9 major differences which are there. If you have any doubt, you can message me, you can leave it in the comment box, and please like, share and subscribe the video, okay, of Persheti's pulmonology. Thank you all for your patience listening.